Today we have with us our chief guest, Dr. Niti Paul. She is currently president of International Diabetic Federation, the president-elect. We have with us our president of Diabetes Asia Study Group, Dr. Abdul Bashir, along with my other colleagues, Dr. Nadima and Dr. Vishwajit. Vishwajit is currently secretary. Yesterday also we have done this program. It's a learning from International Diabetic Federation. IDF meeting was great and grand successful at Bangkok. There were more than 7,000 delegates, but we all know that many of the delegates will not able to join physically. And what we thought that after the meeting, if we can have a webinar like this, where some of the learnings and some of the things which we can discuss, what we learned from International Diabetic Federation, we will able to reach out to many doctors across the Asia. We were having 2,000 delegates who were registered yesterday, and 1,300 were live while we were having the program. Today again, while starting the program, right from starting, more than 300 doctors already joined. And I'm sure in another half an hour, we will have more than 1,000 doctors who will be there. Just to introduce Diabetes Asia to Dr. Niti, this is a group of doctors along with many organizations from Asia who have become the part of this Diabetes Asia. We are regularly conducting a lot of scientific meetings along with annual meeting of our Diabetes Asia, because Elaine may not be knowing more about the Diabetes Asia. A similar type of Asian Association of Study of Diabetes is based at Japan head office, and we have Diabetes Asia head office is in Qatar. So this is what we are, trying to combine both the ASD and DSG and trying to make it more, wide and more organization and more doctors should join it. With this, I will first ask and request Dr. Abdul Bashir to invite formally everyone and to introduce Dr. Niti Paul once she comes back again on her seat. And then we will request her to start formally this meeting. And then we will have 3 session, which is of 15 minutes of each. After each session, we will have 1 or 2 questions. And then at the end, we will have a discussion on a panel discussion sort of thing where 3 important people who will be there to discuss on it. Again, I would like to request Uruj Imam from Pakistan. She is heading the Roche APEC region. And I would like to thank her because she is supporting this meeting. So if Uruj also can, she can open her video. Now I request Dr. Abdul Bashir to introduce formally Dr. Niti Paul and to welcome her for our meeting. And then we can start the meeting formally after introducing Niti and after Niti talk for a few minutes. You please introduce our chairperson and then the chairperson will take it forward. Over to Dr. Abdul Bashir sir, who is president.
Thank you, Banshi, for the kind welcome and introduction. Dear Dr. Niti Paul, President-elect, International Diabetes Federation, Iram Ghafoor and Jackie Malouf, Vice Presidents, International Diabetes Federation, other honorable faculty members, participants, audiences, DASG board, and also the sponsors, Roche Pharma. It is my pleasure and honor to welcome you all on behalf of Diabetes in Asia Study Group for this important topic of translating IDF 2025 into Asia. As Banshi said, that very successful event was there in Bangkok, but obviously not were present there in person. So this is now giving a chance to Diabetes in Asia Study Group to translate what has been there said, the crust of it to the audience here. I am proud to say the Diabetes in Asia Study Group is enjoying tremendous support from International Diabetes Federation, from EASD, from ADA, from AASD, and other associations. And therefore, it is progressing leaps and bounds. Just to remind you all here that Asia is the global hub, central hub of the burden of diabetes. We have the maximum number of people of diabetes. On top of it, limited resources, tremendous resource constraints. Many countries are low middle income countries, and therefore higher morbidities and mortalities and higher challenges we face. And so today's topic of data, devices, and Asian diabetes burden is very pertinent to our population here. I am finally very proud to say that diabetes in Asia through the board of Banshi Sabu, Nadima, Bishojit, and Ashraf has made tremendous progress in the last 2 years by having webinars, conferences, sessions in ADA, ESD, etc. And therefore, I am wholeheartedly grateful on behalf of Diabetes Asia Group to all these colleagues. I am sure that today session will be as scientific and as thrilling as it was yesterday. We had a very rich faculty yesterday, and I am pleased to see a very rich faculty today. Without further ado, I request Dr. Niti Pal to give her address as the chief guest before we start the scientific proceeding. Thank you all.
Hello, thank you, Dr. Basit. It's a great pleasure to be here amongst friends. Thank you, Dr. Banshi Sabu, for inviting me. And Dr. Basit, it's always a pleasure to see you. Every time I meet you, I learn something new. So thank you so much. And welcome to all the others. So it's a great thing that you're doing this so that the messages can get out to most people. From my side, I will be learning too. Unfortunately, I can't stay the whole time. I'm caught up in other meetings in another country. But what I've heard and seen of diabetes in Asia, obviously you have a huge challenge, and the challenge really is to translate that into action. And translating into action in this day and age means using technology better, as far as I'm concerned, and getting public health systems to respond better to this tsunami of a double whammy that a lot of Asian countries have of both non-communicable diseases as well as communicable ones. So I wish you good luck. I wish you success in this venture. You've got my support whenever you need it. And good luck for the rest of the proceedings. Thank you.
Thank you.
Thank you.
So requesting Dr. Basit Saab, you invite both the chairperson for the meeting. Yesterday we missed Dr. Nadima, so I will request Nadima and Bishwajit Momik because Dr. Mohammed Sandir is not well and he will not able to join. So I am requesting Nadima. Dr. Nadima, are you there? Nadima and Bishwajit.
Yes, I am there, Banshi,
Sure.
but I cannot access my camera somehow. The camera is not working.
Don't worry. So Dr. Bishwajit will introduce the first speaker. So over to Dr. Bishwajit.
Yes.
Yes. The AV guy, please give introduction slide of Dr. Irun. Bishwajit, please introduce.
Yeah.
Thank you.
So on behalf of the DASG board, I am welcoming all the speakers. In this session, we have 3 speakers, one from Pakistan, Dr. Gofur, and then from the Hong Kong, from the Dr. Cho, and last one is from the Saudi Arabia, Dr. Box. So first, Dr. Iram Gafur. Currently, she is Vice President, International Diabetic Federation, an experienced faculty member with a demonstrated history of the working in the medical practice industry, skill in the insulin pump, disease management, wellness coaching, hypertension, type 1 diabetes. And she's a has a strong education professionals history with diabetes educator focused by the International Diabetic Federations. Dr. Gofur.
Thank you. Can I share my slides? Are they visible?
Yes.
Yes, just do the full screen. Good.
Okay. Okay. Thank you. First of all, I would like to thank President DASG and the team DASG for providing me such a great opportunity to present in this prestigious conference. And today I am going to explore the next generation CGM systems, focusing on how they have advanced from the real-time glucose tracking to the sophisticated predictive algorithms. So I'm going to start with an example that actually what is the difference between BGM, the blood glucose readings, and the CGM. So there is a profile in front of you that is a illustration that a blood glucose or the SMBGs capture a point in time. If you can see, the patient is only checking their blood glucose at 4 times, and this is actually not a full picture. But if we see the same picture, the same profile with continuous glucose monitoring, we can observe that there are excursion of lows and highs, and this is actually is a complete picture, a complete equation of a patient glycemic profile. And for example, if the patient is having a unawareness, then it can be a very dangerous situation for him if he is not aware with the hypos. So that is how continuous glucose monitoring provide a full picture, which is not only helpful for the people with diabetes, but also for the healthcare professionals, because they can take the targeted decisions, more focused decisions. And if these all the hidden readings get together with the predictive algorithms, then it can change the life of person with diabetes upside down. So since we are talking about the next generation CGMs in relation with predictive algorithms, I would like to portray that how the CGM actually reached to the predictive algorithm systems and how the evolution was there. So the first generation of the CGM was was in the market in 2000, and it was actually the 1999 when the FDA approved it, and it has some key features like real-time glucose tracking and data display every few minutes. But it has some limitations as well, like limited accuracy and that need frequent calibration, like after 4 or 6 hours, and very short sensor life. A maximum that was 3 days. In 2008, the second generation of CGMs came into play, and the key features were the factory calibrated sensors, not all of them, but few of them, and improve the accuracy. The MERD was 9 to 12%. The MERD is actually the mean absolute relative difference, which means the it is the comparison that how it is near to the SMBGs. So that is 9 to 12%, and some of them are having the integration with insulin pumps. And they have also some limitations, like still they were reactive, not predictive, and they had data lag, like 5 to 10 minutes delay. And after that, the third generation or the next generation CGM system, which we are having right now and in future. So they have the right now, which we are having the features that is advanced sensor technology. They have long wearing, as I said, that was 3 days sensor, but now we can even have the 10-day sensor or more than that, and the better accuracy and the predictive analytics and trend forecasting, and also the AI and the machine learning power decision support, and integration with other variables like Apple Watch, like pedometer, Fitbit, and closed loop systems, insulin pumps. But still, we have some limitations. For example, the data privacy concerns, because when the data is on cloud, share with many person, share with doctor, with diabetes team, so there is a data privacy concerns. And of course, these new gadgets has a very high cost, and with lot of data, people are reluctant to have them. The user adaptability is limited till now. So technically, the predictive algorithms are the game changers. They are changing the world of innovation in diabetes. So actually, how that predictive algorithm works. So the first step is data collection. Actually, these CGM systems collect the data, the past data, the current data, as well as the rate of change of glucose levels. For example, 1 milligram per deciliter per minute, and also take the data from the intake of the patient, the insulin, and some advanced system even take the data from stress and from the sleep patterns as well. And then they work on modeling and forecasting. Basically, there is few models like time series models, like psychological models, and the machine learning model. They combine together and make a hybrid model which works in predictive algorithms. And then they calculate the trends, the trend analysis. What is the change rate of the glucose levels? How near is the glucose and the threshold proximity? And what is actually their previous experiences, even the time. They also consider time. So that's how they analyze the trends of the glucose levels and then make predictions and alerts. So for example, they send the proactive alerts. You may have hypo in 20 minutes, or even then, some advanced gadgets, some advanced CGM and insulin pump systems even recommend and trigger the action. And here I can explain that like this, that if that predictive algorithm is saying that my sugar is going to be low in next 60 minutes, then it will trigger the action and my insulin pump gets suspended. And I will not have insulin for next 2 hours unless or until my threshold is so far and it is improved so rapidly, or I manually restart it. So this actually saves the lives. So this is how the predictive algorithm works in new generation or next generation CGM system. So what are the benefits? The first benefit is early warning for the hypo and hyper events. The second is if and then simulation for lifestyle choices, exercise, meal intake, meal type, that all can be seen by the patient. And when they are seeing the trends, of course, they will be careful. And that gives the tighter control over the all the glucose profile, reduce time in range variability, integrate with AID systems. There are many type of insulin pumps out there and other gadgets which are integrated with this algorithm, and that reduce the burden of manual decision making. And I must say that also reduce the human error, because if someone is in hypo, he may take more insulin and it will not enter the correct units. But with predictive algorithms, the insulin pump in integration decide by its own that how much insulin should be injected or suspended. So if we see the broad spectrum, that in future, this integration can be the part of broader digital health ecosystem. For example, that can be paired with different gadgets like Apple Watch, like patches, like other things like pacemaker and things. So they can combine together and take a big decision for the person who is having all these gadgets with them. But similarly, we have some potential challenges as well. The first challenge is that there is too much data, and we usually face the user fatigue. They overwhelmed with the data, with the clauses, with the conditions, with the information, and privacy and security issues. Of course, when they are the cloud-based, they have privacy issues, and they can send alerts to 10 people. So maybe the 10 people know about all this data and everything, and the condition, cost, and access disparities. Definitely, the cost is very high. We all know that, and we have accessibility issues not only with the gadgets, with the CGM systems or innovation, but also for the insulin and the regulatory hurdles. Right now in Pakistan, we have Libre 2, but due to the regulatory hurdle, we can't have the application. And that's why that is totally not possible that we can use that CGM. So that type of hurdles are also there, and they are the big challenges. So what we have right now, I'm going to put some examples. These examples which has backup trials, and they are actually approved ones. So what's first one is AquaCheck Smart Guide CGM, that is not FDA approved, but that has received the CA mark for use in Europe. It predicts lows. It doesn't predict highs. It only predicts lows. And 2 hours glucose production. The best feature which I find in that is nightly hypoglycemic event prediction. For example, I have dinner at 7 and I sleep at 10. So at 10, that will predict that I will have a hypo at 1. So I will so with this gadget, I do not need to wake up. I can even treat that before the sleeping. The other is Eversense 365 system that has predictive algorithm for lows and highs, and wearing time is 1 year. It is the biggest wearing time in all the gadgets. The wearing time is 1 year, and it is FDA approved, and there is the MERD is 8.5 to 9.4, and that can be used in age of 18 above. But this is invasive because it has to be installed under the skin or the subcutaneous fat, and definitely by a physician or a medical person. A person can't have by himself. And another example, which is Guardian Connect 4, that is also a next generation CGM that has predictive algorithm of lows and highs, and it can be wear for 7 days. It is FDA approved, and the MERT range is 9 to 10.8%, and it is recommended to use above the 7 years of age. Simplera. Simplera is the latest next generation CGM system, and it has predictive algorithms for lows and highs, and it has a unique feature, which is that it can be compatible with other devices, like for the heartbeats, for the rhythms, for the walk, for everything. So they can be integrated with them. It is almost like Guardian Connect 4, but what is different is that it is disposable. The transmitter is inbuilt, and it can be very, very thin, very sleek. So even it is not even, you can't feel it over the shirt. So that's why this is the new gadget by Medtronic. And this is Dexcom G7. Dexcom G7 is also a new gadget. Is recently released. I think it was released in April 2025. And the predictive algorithms, they have predictive days, and that give the 12 hours grace time to change the um, sensor. That's why that is 10.5 days, and that is FDA approved. The MERT range is 8.2%, but the best feature is that it can be used in children the age of 2 and above, which is not in any other next generation CGM system. So this is actually, these are the CGMs which are approved, which are widely used, and they have scientific evidences. So otherwise, there are many CGMs out there, but I only presented those which has some scientific evidences. So in summary, the next generation CGM systems isn't just about knowing glucose level now, but it is about knowing what next. And the predictive algorithms, when combined with AI-powered decision support, transform the diabetes care from reactive to proactive and empower user with real-time insight and future-focused guidance for optimal metabolic control. So that's all from me today. Thank you.
Thank you, Room. Can have some question, Vishwajit?
Yeah, I want to ask one question from my side. How do
Please.
you ensure privacy and security?
The privacy in
And
the
the
terms of
security.
very well taken, because for example, you are the doctor and I am the person and I have changed my doctor. So I can close your account from my gadget, and I can make a new user. For example, I am now my physician is Dr. Bansi, so I can make a new account. So this is how we manage the privacy, and it has proper applications, and even they tag your like finger prints and everything. So and the security wise, it is right now the new CGMs, the data is much secure because they are cloud based and they have different interfaces. So we need to cross them. So normally, if I am correct that you are asking about the hacking, because previously the system get hacked, but now these are taken care from. That's why I have suggested only those brands which are very secure.
One very important question is regarding the predictive glucose monitoring. See what happens, suppose one of my type 1 who thinks that after 2 hours, her sugar may go down because this predictivity is showing. So it is good way that she can protect herself from hypoglycemia by taking something else. But will you don't think that this may increase the risk of increasing hyperglycemia too? Because she may be taking some extra amount of sugar or maybe taking less amount of the insulin, thinking that she may go in hypoglycemia because it gives you more prediction in after 2 hours. So do we have a data to support that predictive continuous glucose monitoring in compared to real-time continuous glucose monitoring, both the arms with a almost not, we can't do a double blind placebo, but still
I'm
we have
sorry, sir.
data.
Actually, I was disconnected. Can you please repeat your
So my
question?
question is, Irom, that what happens, suppose it's a predictive continuous glucose monitoring, and you don't know that after 2 hours, the sugar may show slightly down because it is predicting that after 2 hours or 3 hours, sugar may go down. So the person with type 1 diabetes, particularly type 1 diabetes, I'm talking, that they may, proactively trying to correct that by taking some extra amount of the glucose or maybe taking less amount of the insulin at that point of time. Will it increase the sugar level for that next 2 hours? Because you are trying to decrease your chance of getting sugar maybe after 2 hours. But here in that 2 hours, you are increasing actually your sugar level. So do we have data of predictive continuous glucose monitoring versus real-time continuous glucose monitoring, which is already available to us, showing that it is superior? It may be superior for decreasing hypoglycemia risk, but can it increase time in range? Will it have less hypoglycemia, but will it have less hyperglycemic peak? and how many times a person is actually trying to take extra snack or less amount of the insulin just to make sure that he is not going in hypoglycemia.
Sir, actually, the predictive algorithm works like this because, as I mentioned, that it is not even touching my threshold. It is not even touched. For example, I have set my sugars that it shouldn't be less than 90 milligram per deciliter. So it will not wait for 90 gram per deciliter if I have just like it take all the inputs. So if I mention that it is 150, then it automatically suspend the insulin and give me the alert. So this is actually the beauty of this. But there is only one CGM which covers 2 hours, because maximum the CGM covers 15 to 60 minutes, not more than that. So, but I have experienced that with myself. The alarms are very good. You can even hear in the next room. So that's that. But in type 1, it is very helpful in a way that the episode of all the hypoglycemic events get reduced almost to none, which is very very important for those, because I have many patients who are having many episodes in a day, so it helps in this way.
Thank you. So
Thank you,
Vishwajit,
sir.
Nadima, again I'm requesting for our next speaker introduction.
Yeah, thank you, Dr. Gafur, for your nice presentation. Now we move to our second speaker. Second speaker is Dr. Ellen Cho from Hong Kong, and she will talk on towards integrated care, old versus the new. So I already mentioned about the Dr. Ellen Cho, and she's now the Associate Professor, Clinical Department of the Medicine and Therapeutics, Deputy Medical Director, Faison Clinical Center, Faculty of Medicine, the Chinese University of Hong Kong. She's also the Honorary Associate Consultant, Prince of Wales Hospital, and expertise in the clinical pharmacology, cardiovascular, renal, metabolic disease, and clinical trials. And she's done a lot of the research work. Now I'm welcoming Dr. Ellen Cho for her speech.
Thank you very much for the kind introduction, and thank you so much for the opportunity to speak in DASG. And thank you to Dr. Sabu. I'm really very privileged to be able to speak today and share with you all the very exciting insights from the IDF meeting. So let me just check I could share my screen. Yeah. Okay. Is that okay?
Yeah.
Okay, great. I mean, I was so excited after attending the IDF meeting, because I felt there was such enormous energy. There was so much interconnectedness, and especially being held in Asia, I felt there was so much synergism both between the different parts of the world. I chose this particular theme towards integrated care, old versus the new. Because I just thought it touches on a lot of the key themes that were talked about in the IDF. So I mean, there was a lot of material to cover, but I've just selected a few talks. I guess we will, there was a lot of talk about obviously the newer medications, the SGLT2 inhibitors, the GLP-1 receptor agonists, in sort of particularly cardiorenal protection, and also insulin analogs. We just had the wonderful talk from Aaron Gafoor about CGM and newer generation sensors, and excitement around the automated insulin delivery systems. Also precision medicine, particularly genetics, multi-omics, and even sort of gut microbiota. But with all this excitement of these new technologies going on in the background, we must not forget about the traditional therapies, and how the question is how we should integrate that to really achieve the best outcomes. So the first series of talks I would like to share was a session about the GLP-1 RA and SGLT2 inhibitors are on the front line, but can we afford it? I thought that was quite a thought-provoking session. So this is the latest IDF 2025 recommendations, and we could see here that of course lifestyle modification, metformin is still at the sort of the basics of therapy. But now, we are putting SGLT2 inhibitors, at much more in the forefront, both for people, with cardiovascular complications, and also as an option for even people with lower cardiorenal, risks. And of course, we see great movements in having SGLT2 inhibitors available in even lower middle income countries. But even in places like Hong Kong, we are struggling to have access to SGLT2 inhibitors, across a broad population, both with and without diabetes. So I was going to share the talk by Rupa Mehta from Mexico. And she shared a view about, whether the pendulum has shifted too far. Of course, the UK PDS and other studies really, highlight the importance of, the legacy effect, the importance of early, glucose lowering, which will reduce both, micro and possibly macrovascular complications in the long run. But you could see here, as this is, enhanced data, and we could see that in the recent, 5 to 10 years or so, actually, we have, the glycemic control has not actually, improved despite the availability of more, better glucose lowering drugs. And we reflected whether this could be due to maybe system factors, clinical inertia, poor adherence, and at the same time, the use of these organ protective medications such as SGLT2 inhibitors or GLP-1 is still actually, rather low. So also, this is a very nice talk by Professor Fiona Chan from Hong Kong. And then she she reminded us of the difference between the old drugs versus new drugs. And she presented a network analysis of efficacy of 9 classes of glucose-lowering drugs in RCT, settings. And you could see here, ranging from, drugs such as alpha-glucosidase inhibitors, metformin to GLP-1s. Actually, most of them are good drugs. So, they can all show an average of lowering about, 0.7 to 0.8% in HbA1c. Even, amongst people on monotherapy and also on people on background, metformin therapy. And this also raises the point, what about those 70% of patients with no CV complications at baseline? Should we think about making access of, drugs that are may possibly, more older, just established, which are more affordable? So that was quite a, thought-provoking comment. And again, she also presented some real-world data from, this is from Denmark, from a nationwide register. And you could see that about 50% of patients treated with a GLP-1 receptor agonist or SGLT2 inhibitor actually discontinued their treatment, within 3 years. And only approximately half of them had treatment reinstituted. So, I think this pattern is also reflected in many parts of the world. And I wonder whether, locally you also experience a certain similar trend. And for us, even in Hong Kong, it's not to do with affordability, but also possibly due to tolerability and also maybe supply issues. So again, that is something that, we ought to reflect on. And finally, in that session, Dr. Warundi from Thailand, from the HITAP, so she shared a very important perspective on the cost effectiveness of GLP-1 RA and SGLT2. And again, I think it's raises a very important point. When how we can negotiate affordable pricing and equitable access to these drugs. And again, I think we need to think about the data evidence, which needs to be context specific, and also important to evaluate and monitor the cost effectiveness in real world. So she shared some examples of the economic valuation of, for example, a range of drugs that to be included in the Thai benefit package. And and she showed that using cost-effective analysis, certain drugs can undergo price negotiation and to make it make the access possibly pricing more affordable. And also, she shared some studies where they looked at SGLT2 inhibitors in real-world population, and again, this is a cycle that ought to be maybe a tool that can help help policymakers make better decisions with regards to drugs that are also maybe in future coming along, such as the future dual or triple agonists of GLP-1 RA based therapies. So the other session I would like to share is one we participated in together with other colleagues, Sunny Wong from Singapore and also Aram, who spoke just now. So the topic of that session was diabetes care, tradition meets science. So I highlighted that despite these newer exciting drugs and tech available, a lot of people are still using what we call complementary and alternative medicine, CAM. And in some surveys, approximately 50% people with diabetes said they have used some form of CAM at some point in their treatment. And I think it's important to think about how we can actually integrate both conventional medicine and CAM using an evidence-based approach. So I covered the sort of several key classes of CAM therapies. So for example, herbal drugs. Here we cite example of berberine, which has been used as part of traditional Chinese medicines for a long time. Other drugs such as fenugreek, bitter gourd, that a lot of people with diabetes might take in other parts of Asia. Supplements, which has really been an exploding market, and especially, for example, magnesium or selenium, that has possibly got more evidence base in maybe helping with diabetes and other related complications. I highlighted the importance of, for example, mind-body therapies, yoga, that has really potential to improve holistic health. And also, Dr. Sunny Wong highlighted, the increasing use and popularity of prebiotics and probiotics and modulation of the gut biota, which again might be helpful in management of diabetes. And also, in the IDF sessions, we heard a lot about tech and also AI. So I attended the really fantastic talk by Amit Day, where he really highlighted, the potential role of AI in future, both in clinical decision making and also maybe predictive analytics. So, I think there are probably more established AI tools that are available, such as the retinal screening. But I think what is more of the unknown is use of AI in clinical decision support. So, for example, using AI chatbots, whether we can use this to enhance medication adherence, whether this can actually maybe reduce the education gap and enable access to more specialized care. So I think in general, the field is moving much faster than our physicians or systems are able to grasp. So and again, I think this is a very important topic that we should hopefully revisit in the next big IDF meeting. So finally, Aaron Gafoor really highlighted the importance of the view of people with diabetes. So, I agree. I think most of the people we look after fall into several camps. So we have people who are more comfortable with more traditional approaches. So they're much more, akin or feel comfortable with natural remedies. And they often have, concerns about medication side effects. And on the other camp, we have some science and technology advocates. They're willing to embrace and try something new, whether it's CGM or pumps. But again, they have sometimes concerns about the cost and also the complexity and potential burden of using these technologies. So on the whole, I think, we need to think about how we can adopt a balanced approach. And we had a great panel discussion together with the audience and discussing sometimes how, the views of HCPs may actually conflict with people's views of diabetes. how we should handle that. I think Mohammed Hassan really sort of illustrated a very good example, and I think it's using the example of the IDF and DAR, the risk application to advise people how they should monitor or manage their diabetes during Ramadan. And I think we should future approaches really take into account of both views of people and how we can best embrace these technology in a person-centered manner. So, I mean, I think there are lots of future challenges in integrated care. So, I mean, how can we evaluate these CAMs in a scientific manner? For example, lots of TCMs have multiple components, and whether we can utilize more complex analytical tools to enhance quality control. And I gave an example, for example, in Hong Kong. So we have now adopted integrative care clinics where Chinese medical practitioners also work alongside Western doctors, and our Chinese medicine hospital is about to be launched. So again, I think these are lots of potential solutions that we can think about implementing in Asia in future. But I think the final and the most important point is the access and equity issue. There was a fantastic panel discussion with representation of different parts of the world, and I think what are the global disparities due to? I think some of it is due to socioeconomic factors, but I think most important, to me, is the human resource. So the need to have trained, dedicated medical staff, which is key to helping us implement the technology and solutions, and having the political will and engaging people with diabetes to really together advocate for better access to both medications and tech. And in fact, this was what I've been translating when I came back to Hong Kong. So in the next week, we still don't have CGM reimbursed in Hong Kong. So next week, together with some NGOs, Professor Ronald Ma and others, we are going to launch our first technology forum, a multi-stakeholder meeting to try to really find a pathway to getting CGM and pump access in Hong Kong. And also, we are, believe it or not, the majority of patients in Hong Kong are still on some NPH human insulins. And again, affordability of these essential medicines is a key, really across the whole of Asia. So I'd just like to end on a quote, actually, I borrowed from Aaron Gafoor. So I think the key towards integrated care is really combining old wisdom and innovation, and how we can really find the best path forward for helping people self-manage their condition. So thank you. And if I don't mind, I would also like to take this opportunity as for a quick advert. We are holding our annual East Meets West Symposium in Hong Kong at the end of September. So this is a meeting where we'll be covering lots of important topics such as diabetes prevention. We'll be talking about newer generation CGMs, and we've invited speakers from many parts of the world. And there is also a young investigator travel grant and a young abstract competition. So everybody is very welcome to attend. So this is a QR code. And hope we could maybe see you, many of you, in Hong Kong sometime in the future. So thank you very much.
Thank you, Elaine, for your nice presentation. So I have one question to you.
Yeah.
So after having all the new molecules, still all the glucose parameters remain above the target levels in the most part of the world. So how do you explain this?
Sorry, I missed that. Can you say that question again? Sorry. Oops, sorry.
So we have all the the new molecules.
Yes.
In our hand, but
Yes.
still all the glucose parameters are remain high. They're above the target levels. So how do you explain this?
So the question is that with the multiple drugs which are already there, still
the new molecules is there, all
new
the new
molecules. Yeah. Great question.
Plus the technology is also there.
Yes. Okay. Yeah, I mean, I think, yeah, as I say, I mean, it's interesting because we adding more drugs on, and especially in Asia. I mean, I think one is that you know, I mean, with it, that's in Asian diabetes, we tend to have a lot of beta cell dysfunction. And I mean, to this point in time, apart from giving insulin itself, we can't actually, completely restore that defect. So, what other drugs we're giving is probably trying to slow down the process. I think, having these drugs is one thing, but I think it's mostly the education, having the nurses behind us to help us enhance the adherence. And I think it is um, I mean, I think it's having the time to talk to people as well. I mean, I sometimes think, okay, tech CGM is fantastic, but how do you really engage people to understand the condition, empower themselves? I mean, I think, I think last week I was in a diabetes clinic, and I had this young gentleman in his 40s, and I asked him, would you want to have a more potent GLP-1? Shall I increase your Ozempic, as semaglutide up to 2 mg? And then he said, "Oh no, doctor, it's actually not necessary. I've decided to do running, 3 times a week, 5K, and look at how fantastic I've done. I'm also using a CGM." So I think these are the conversations we need to have. It's about how we can implement these new medicines and technologies, and with the people behind it. And I think we need to invest in not only in the meds, in also in the people. So, yeah. So, yeah.
Dr. Bansi, do you have any question?
So I was surprised when Ellen told me that in CGM is not
No.
regularly reimbursed in Hong Kong market.
No,
I mean, so
no,
many companies must be there in Hong Kong. They must be
no.
manufacturing their
Yeah,
operations.
I know. It's so I mean, your talk made me reflect. I think I really agree with you. Multiple factors. It's not only the socioeconomics, but also maybe political will, advocacy, and all these factors need to come together. So we're working on it. So I mean, I think maybe you're doing a fantastic job in India and other parts of. I know many countries in Asia have it already, at least for people with type 1 diabetes. So yeah, so
Good.
great.
So do you recommend the traditional medicine in your diabetes practice?
Yeah, I mean that's fantastic. Number one, I mean I think I tend to, people, I would tend to support people if they said, doctor, I'm taking this particular bitter gourd supplement. Do you think it's going to do me harm? Then I would give them an honest opinion, and to just say, well, I would not use this as a substitute against for your other medications that you're taking. Um, but I mean, I feel that offer people a integrated approach, a more balanced approach. Ultimately, is going to foster a better patient and doctor relationship. So I mean, again, I think a lot of these traditional medications, for example, even think about metformin, it came from a herb, right? So it came from a flower, and even dapagliflozin, they came from a certain plant. So and again, I think having people to feel comfortable with the way they're managing diabetes and respecting the beliefs and traditions rather than challenging them would be the most likely to the productive way forward. So yeah.
Good.
Okay, can we move?
Thank you.
Yeah, thank you. So now our third speaker, and he is Dr. Abdul Mohsen Box from Saudi Arabia, and he will talk on effort to save insulin cells in type 1 diabetes.
All right. Thank you so much, everybody. And good evening from wherever you're joining. I would like to thank the organizers for giving me a chance to speak, the Diabetes Asia Study Group, and to talk about, reflect on some of pretty much carrying on the same theme, I hope, finding ways to preserve the cells, especially for type 1 diabetes. It's no longer just imagination. I think it's reality now. These are my disclosures, and hopefully in the next 15 minutes, and might go slightly above time, but I hope that would be fine. We'd be going over the prevalence of T1D and its environmental and genetic drivers, autoimmune mechanisms, and disease staging, predicting disease progression and the relevance of remnant C-peptide, and the rationale for screening and identifying who would be screened. So just before I start, I just want to in my humble opinion, I believe there are currently three hot topics for research in type 1 diabetes. One involves prevention. Second is tech, which was very nicely covered in the previous lectures. And the third is islet transplant / stem cell transplant. My idea, I focus on all three. But preliminarily today, I'd be speaking about the first part where early detection and what that entails for our population. So without further ado, I'd get started. So this is actually a slide that I always put as a tribute to my mentor, Bruce Perkins. That's Banting and Best. I'm pretty sure they were from Toronto, and I got trained in Toronto as well. And Bruce is actually Canadian, living with type 1 diabetes as well. So I think more than 100 years of insulin discovery has passed. I'm sure we should move on to more early detection and immunoprevention methods or ideas to detect this disease before it happens. Just to give you some idea about the landscape, currently at the moment, there are almost 9.2 million people. This is from the IDF Atlas 2025. Around 9.2 million people are living with type 1 diabetes globally. 1.8 million children and adolescents are living with type 1 diabetes. Of those, 30,000 children and youth will die non-diagnosed at clinical onset of T1D. And to think that this is a disease of the Scandinavian countries or in North America is very wrong, because us here in Saudi Arabia, we stand at number 9 in terms of prevalence and incidence. And we still represent Asia and the Middle East. And I think the numbers are pretty staggering. These are from the Type 1D Index Registry. We are nearly almost up to 250,000. This is a definite underrepresentation of the number. And just to give you an example, a fellow country within the Middle East, Kuwait, which is a very small population, they have 43,000 patients as well at the moment, and not to just mention the healthy years that are lost per person. So we all know type 1D is a chronic progressive disease. Despite advancements, as was previously mentioned, 70% of the people will not achieve adequate glycemic control, leading to premature mortality, cardiovascular complications, and with that, several years of life are lost. All in all, there's definitely a unmet need for therapies beyond insulin and beyond technology. In terms of survival, I think the story isn't really different. Men who are diagnosed before age 10 years tend to lose around 15 years, and women diagnosed age before 10 years also lose around 17 to 18 years of life. And I don't even want to go into details. There was because of the sake of time, I did not include that slide, but due to disparities of insulin, particularly in Asia, that number is substantially a lot higher. So some of the really great cohorts that really studied this disease are from the UK and the US. Some of them from the US is from the DASG study or the TEDdy study. What they traditionally found, now we're moving towards the more of the nutritional and the environmental factors involved in T1D. And I think this is a very controversial topic that always gets brought up. But what's been found from these big cohorts is that cow milk is actually does not increase the risk. Omega-3 are protective above age 11. The TEDdy particularly found that there is an impact of infections, probiotics, micronutrients, and overall there is an increased reactive oxygen species. What's interesting is that nutritional intake was also associated in some studies, particularly not the stuff that we're eating, but how our internal or endogenous exposure relates to this. So overall, there's already enough heterogeneity, and imagine adding nutrition to it as well. We know genetics, so I'll just break down some of the risk factors. We know genetics almost very low. 0.4%. There's a 15-fold higher in first-degree relatives with type 1. Monozygotic twins, 30 to 70%. So what's clear, or what's commonly understood, that this is a genetic disease is not entirely true, because if that was the case, then monozygotic twins will be. However, if you have patients that have parents that have type 1 DM, you would definitely see that men with type 1 have an increased around 6% risk. Women, if they're diagnosed with type 1, or sorry, if they're aged less than 25, 4%, if they're aged more than, so a higher age is somehow protective. There's a really nice paper, again, published at the ESD last year as well, which kind of eluded this specific point, that somehow there is a maternal protection in offsprings born to mothers who are already diagnosed with type 1. And if there's either parent diagnosed at the age of less than 11, that just doubles your risk. And obviously, if both parents are involved, 10 to 25%. So really, genetics doesn't really cut it, for which there are a lot of genetic risk scores. We do know that there's a particular HLA predisposition, especially the DQB1 and the DRB1. And these genetic risk scores, again, were based on European ancestry. So GRS1 first, and then the GRS2 came along. However, not very applicable to, I believe, our population or this part of the world. But what's even more interesting is that, genetic risk scores are static risk scores. You either have it or you don't. What's definitely needed is a more dynamic risk factor assessment. So is antibody progression just the sole idea? Well, I think this is, again, very interesting review paper in Lancet published last year, which showed that what would classify as static and what would be more dynamic. In terms of dynamic, you would have your genetic, clinical, individual, socioeconomic statuses. We saw there was a clear surge recently with COVID. Was that responsible? And then all these other biochemical markers that are often overlooked. For example, I would just highlight one, chromogranin A. There's a really nice paper on verapamil and new onset type 1D and how that's been protective. What really was highlighted in that paper was that people with type 1 usually tend to have very low chromogranin A levels. And with verapamil, these levels were restored to more normal levels. And then you can obviously go into the more molecular level and see that, again, there's, due to severe heterogeneity, there is still a lot of work to be done in this field, but I feel like that's picking up as well. So overall, I believe risk scores that capture a more a dynamic picture needs to be developed, especially for different population. So now moving on to the autoimmune nature and staging of T1D. Before I move any further, I think just to start off, this is from the ADASD consensus. Again, testing autoantibodies, again, that's not even available in some of the developed countries at all centers. But I think that's what this paper highlighted, or this consensus highlighted, was that the basic need. And then I know trouble starts when you have an autoantibody negative, which could be around 10% of the population. But I think this is a very interesting pathway just to keep in mind if you're facing somebody with age less than 35 years, you're ruling out the monogenic features, etc. And then if you were to test their C-peptides, that could give you definite hint. And obviously, if age more than 35, more so treated as, obviously, if you've ruled out everything, more so treated as a type 2, and with C-peptide levels done after 3 years. So we know that there are 5 antibodies that are classically associated. But what's important is realizing that this was a paper from which kind of established across almost 10 cohorts, where they did was that they took the antibodies and made it into clusters. Which cluster was most likely to develop? What 2 really good findings that they found was that the cluster with the IAA, the triple antibodies, these, if they were present, more likely to progress to type 1D. Similarly, initial presentation of the IAA antibody was more likely to be aggressive and to disappear sooner as well. So some of these, I think, are key factors. I think the way this field is really excelling and progressing Everybody knows teplizumab is approved. We just had the launch actually last week, and we're from one of the top 5 countries that actually it's been approved in, and very soon it's going to kick in. The cost might matter, but then, people will always be looking for cheaper alternatives such as verapamil and Mounjaro. I've been lucky enough to actually have a patient started on that and actually then received the teplizumab, and it's been phenomenal, like what these alternative drugs can do. And to start off all of that puzzle, I think antibodies would definitely play a role, and understanding the different clusters, not just your genetic makeup. It's a lot more your nutritional, your environmental factors, your antibody status. It's all going to play a role. So with that, I think we're all aware that there's now a new staging. However, this was initially described by Eisenbarth around 1975, where that concept of staging was put into place. So let's say you were to have a genetic risk, and then you get a trigger from some of the triggers that we did mention, whether that's an environmental trigger, whether that's COVID, viral infections, Coxsackie virus, etc. You tend to tip over to the stage 1. Your blood sugars are normal, but you have those 2 autoantibodies. And then at stage 2 comes in where your abnormal blood sugars, however, you have developed dysglycemia as well. And then obviously stage 3 is the full-on ADA diagnosis, and stage 4 would be your established. And clearly, stage 2, within 1 year is almost 75% you're likely to develop type 1 diabetes. Some meta-analyses have shown 74, but definite 5-year risk is around 75%. And what would be that dysglycemia, whether your fasting sugars are this, or your OGTT is around 140 to 199, or even 5.7 to 6.4, or more than 10% increase in the A1C. I'm sure somebody jumping from 4.5 to 5.7, it's still normal. However, it should ring an alarm that something is going on. With that, I believe what we've covered initially, I strongly believe, and this is another idea that I was discussing as well with my colleagues, that I actually gave a lecture about that, the role of technology in this group. And I feel like that's going to definitely come into play with, OGTT is probably not the best or the most ideal test to be done. So this is just a more mechanistic model where we see where exactly the autoimmunity would go in effect. And, B cell antagonism, inhibition, T cell activation, cytokine antagonist are all involved to eventually lead to the beta cell apoptosis. Having said that, TXNIP is the actual receptor where verapamil, the calcium channel blocker, works. So why is preserving C-peptides so important? Well, just before I go into those details, classically, your type 1 develops when you're left with 25% of your beta cell mass. And we've seen that with the famous DCCT trial, which I was, again, lucky enough to actually look after DCCT participants and be at the Toronto site. Lucky enough to see that certainly certain patients that had preserved C-peptide had lower A1C at year 1. Total insulin dose was lower, retinopathy progression was lower, and lower incidence of hypoglycemia. And it's not surprising that we're actually coming up with a publication soon where C-peptide, obviously, it's actually helped preserving, decreasing decay events in those that had preserved C-peptide. So, and just to top it off, this C-peptide really is outlined, especially in the islet transplant world, where patients who did receive those islet infusions eventually had better time in ranges, lower rates of complications as well. So to recap, incidence is rising pretty dramatically, around 60 to 107% by 2040. And I think it's going to take all of us in, all the countries, everybody. There is definitely a family history risk, and yes, you do tend to develop higher, but I feel there's a lot more to type 1 diabetes that rather than just genetic risk. Cardiovascular complications, the prevalence of decay is very high, and obviously the years lost. We talked about the staging. Now we're going to talk about why to screen. I know this may seem a very like there with classical insulin disparities around some of the countries around, why do you even screen? I think it still will hold its value, as I'll show you some data where screening actually helped reduce a lot of the complications and hence economic burden. With that, I'm just gonna outline some of the things that have been studied extensively and how it's impacted the future. There's a reduced burden of daily self-management, obviously in those that are screened. There's attenuated long-term diabetes complications. Socioeconomic impact is definitely an impact. Families, caregiver impact. There's an early detection ecosystem from all the screening. Psychosocial, reduce negative, more acceptability towards your disease or owning. I think this was a point that was mentioned earlier. The fact that you can empower. I think a lot of the times we fail as physicians to empower our patients, and this kind of begins to do that. Well, like I said, DKA at diagnosis has been studied to find out long-term memory deficits, lower cognition scores, altered brain growth, a sustainable negative effect on glycemic control over time as well, linked to increased morbidity and mortality. But what's surprising is next, 60% in countries like US actually come up to the hospital with a DK event. So again, this is where I would like to again emphasize, I know there's a lot of, this definitely helps engagement with policymakers, why this is important, even where socioeconomic or economic burdens are huge. I think presenting patients and having them stay over for almost 7 days in a hospital or whatever duration that might be has actually caused increased costs on the healthcare systems. As a matter of fact, there's a really good paper on diabetes care again. Around $327 billion are spent on diabetes care in the US. So even if you were to 1/3, if you were to give it to type 1, that's still $100 billion. And I can't even imagine like how much reduction in complications this screening program could do. Similarly, again, these are some of the famous trials, the famous cohorts that have looked into this screening program, and clearly there's a substantial difference in the DK rates amongst those that have been screened early. Again, a point that's very underlooked in caring for diabetes, the impact of the burden it carries around with their healthcare givers. So yeah, this was a study done on comparing mothers who had their children screened versus those who didn't. And clearly there was a better reduced psychological distress in those that were diagnosed earlier. So the question comes in, who to screen? Well, first and second degree relatives is ideal. What really intrigues me is this middle part, celiac. How many times we have patients showing up with celiac before, or autoimmune thyroid? So this is some of the more population strategies we can use. General population, I think Italy has started it, but I think we're a little far from that. And then obviously newborn genetic testing, which was kind of looked into in Canada as well, but then that comes with its own problems. So again, we all know celiac disease, people living with Graves' disease and Hashimoto's disease do have a higher incidence of type 1D. Maybe targeting these screening populations would be of really good help. And then these are some of the scale of T1D screening programs around the world. Unfortunate, us in Asia or Middle East aren't being part of it. However, I do have good news. Actually, our institution, specifically King Faisal Specialist Hospital Riyadh, we've started a screening program, and it's going well. Lastly, I think just the classic problem of misdiagnosing. Some of these key pearls to look out for: age. Even though type 1 is a trimodal distribution, but sometimes age can help a little bit. And obviously, we talked about the autoimmunity and BMI. The family background definitely helps. Worsening control on non-insulin therapies, excuse me. And then obviously early development of comorbidities. I do work in a renal transplant center as well. So I see a lot of these type 1s, barely 25, 29s, undergoing renal transplant. So the destruction is pretty rapid. Definitely this deserves our attention. And with that, I hope I did not go over time. I hope in the previous 15 minutes, we were able to get a somewhat better understanding of the prevalence, the autoimmune mechanisms, why disease progression and remnant C-peptide matters, and what's the rationale for screening and identifying those to be screened. With that, thank you so much, and I'd be ready to take any questions.
Thank you, Abdul.
Do you have any questions?
I have. So, fantastic presentation. I just want to ask you, do we have any specific clinical markers? Like as you told that those who have Graves' disease or those who have celiac, their sibling should be tested for the, having the chances of getting type 1 more. But any other marker, I mean, any genetic, or if they have dual antibody positive or a triple, then definitely their sibling should be done, or a one particular age of onset. Suppose you have a child, her or his age is less than 5 or less than 10, whether their siblings are more prone to have, or someone who are developing type 1 in the adult age. That's number one. Second is, as you already started screening in your center, so I have my database, which we have presented also in SPAD, and in my suite registry data of 1700 type 1, which we are taking care currently, out of them only 23 siblings are having type 1. I mean, both it may be brother, brother, sister, 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 brother, and then around 7 odd combination where your father and son, or father and daughter, and mother and son. They are the 7 one. And then one family which I have with a 3 kids is positive. I mean, 3 of them, not even 2. All 3 are the type 1. Then I have one family where the 2 kids and one mother is also type 1. So this is all different. So this is total number is not less than, out of 1700, it's more less than 35. So
Yeah.
that was the one
Yeah.
question. So I would like to ask that what is the situation in Saudi Arabia when you
Okay.
started?
Yeah, they're very, very interesting questions. Thank you. First question about biomarkers. Honestly, see, this is again the beauty of the unfortunate part of type 1. There's so much heterogeneity that if you were to look at, this is why I like, and I think this is my practice is probably going to change in the coming months. I've developed like a genetic part, there's a nutritional part, there's a viral part, or infection part, and then there is just bad luck, and probably some metabolic or proteomics are going to come in the future, in the near future. We don't know. So what I do know is, and what's really definitely there's a genetic element to it, but the fact that if you're born with some autoimmune element, you're automatically at a higher risk, and that comes with the HLA genes as well. People with, for example, rheumatoid or SLE, they carry the same genetic makeup as well. I think to start off with, because this is a relatively newer field, and places like Italy are doing like a nationwide screening, not really feasible for our situations, but if you can narrow down some autoimmunity and link it up just to have some screening early on, early detection, I think that's the way to go. Just keep it simple. You see some autoimmune patients, SLE, etc., celiac, Hashimoto thyroiditis, like often at times you do tend to find, early onset hypothyroidism as well. Just do a TPO, see some autoimmunity. If you do, screen as well for that. So in terms of your second question, and I just want to make, I feel it's my inner hunch, chromogranin A levels will play a definite crucial role in the coming years, because they're just surprisingly and very low. And like I mentioned, the example of one of my patients that I started on verapamil, it literally shot up to like normal levels. I was shocked. I didn't know what to do. And just to like look back to the literature and be like, wow, this just really happened, That's one thing. Second, in terms of like how the situation is here, I think we are we have very consanguinity, like marriages, like within the family marriages, like cousins, etc. So somehow there is an onset, and somehow there is just, like it's going. We've had actually, just to quote one case, was the daughter was diagnosed with type 1, and the father was a physician actually, who came and somehow they both, so they brought the son and the daughter to the private clinic. Son goes, the father was like, you know what, let me just run the antibodies on the son as well. Guess what? Son has the antibodies, never got diagnosed. The sister already got diagnosed with an autoantibody negative. So it's happening. There's a lot of heterogeneity, which is why I want to like conclude with one point, is that I think we need to have our own dynamic risk scores, not just genetic risk scores where you find out the population of certain genes in our population, not just that. Add, for example, what antibody at onset is more common in our population. Is the IAA, IA2A, or the GAD65? And this local data just to promote this. And we're currently working on this, to set up some sort of a local data platform for people to look into.
So we started doing now at least 2 and 3 antibody, autoantibody, including Z and T8 also. And many of our patients with a dual antibody positivity. And we found that after GAD, it is IA2, which is more common in Indian situation. As also we have done the presentation. And what you do, suppose your sibling in your country, Saudi Arabia, which is a developed country of Asia, if you find someone positive with dual antibody, or if you're dysglycemia, also in continuous glucose monitoring,
Stage 2?
only thing other than that, you can prevent the diabetic ketoacidosis. At present, do we have anything for immunotherapy? Even Italy does not have it present. They started doing the screening. We have teplizumab, which is only available in US markets, not anywhere else. What's the situation? And do you have any research which you are going on in your country related to other immunotherapy other than that teplizumab?
Okay, great question again. So so teplizumab is available in Saudi. It became available last month.
Oh, great. That's good.
Yeah. So we're actually the 5th country in the world to actually take it or get it. However, what I believe, I think what I was even discussing at the launch event was, I don't fear that we're gonna have teplizumab. That's great, but I do fear because of the cost, we're not gonna be able to do all these screened patients, give them the option of getting a $500,000 medication. It's still very costly, even for developed countries. Almost similar costs, around 200,000 US dollars. I think that's a huge cost if you were to go on insurance basis. So if my concern is the same. You screen, you find a lot of patients, then what? Let's say you give 30%, 40% teplizumab, what happens to the rest, 60%? Well, in that case, this is where I strongly believe high dose vitamin D is going to come into play. There's a really nice paper in JAMA actually, which shows that patients with type 1 diabetes have a very high pro-insulin to insulin ratio because of the immature granules that come out a lot earlier than the insulin. And that immature granules, what they did was they gave very high doses of vitamin D, and that pro-insulin levels actually went down over time. So this is my own cocktail that I like to use along with verapamil and Mounjaro as well. I know GLP-1s, there was a really nice paper on New England Journal with the 10K series patients, all of them off basal insulin. All of them off prandial insulins, and 1 or 2 patients had remaining basal insulins. But I feel like Mounjaro might tip over this space. There's just some sort of a better protection from apoptosis. So that's that. And then there is a very new drug that I was working in as a in part of a trial in Canada. These are menin inhibitors. So what they do is basically they actually replicate whatever mass you have left. They cause some hypertrophy in that mass. And I think this might be another mechanism for the Mounjaro as well, that it can somehow cause hypertrophy of those cells, the beta cells, remnant cells. But this is some of the drugs to look out for. In our current practice, I think we're building up a protocol for maybe introducing verapamil with Mounjaro, at least for adult patients.
Verapamil, GLP-1, they all are tried, but other than these are the immunotherapy. One last question to you. There is a baricitinib that also the clinical trial in phase 2 had shown a significant improvement in C-peptide level, and it's in already off level. It's not like teplizumab. So do you think that, a molecule which is already off patent, which we have used for SLE and rheumatoid arthritis, it is available even in many parts of the world. Do you think that in future that sort of a molecule which is already off patent can be used, or a multiple immunotherapy can be used? I mean, putting the patients on different immunological agents, including diltiazem including verapamil and GLP-1 and all also.
Yeah, great question. I forgot to mention I was part of the ustekinumab trial, which is commonly being used in psoriasis. This was done at the pediatric level in Cardiff, UK already, and we were doing the adult patients. The results will be published soon, but initially amazing results. And just to continue that thought, I think we've found some drugs do work, whether it's for stage 3 or stage 2 for a certain time or not. I think what's coming in the future is multimodal therapies, which combination tend to go on for longer. And as a matter of fact, the same verapamil teplizumab combination is currently being studied in Cardiff as well, UK. It's being currently studied there too. So I think in the next 5-6 years, this whole type 1D with the stem cell transplant, the tech, it's going to explode this field.
Maybe in after 10 years, we will not discuss much about this. Only therapy, only
Yeah.
cure will be there. The next session of panel discussion where we'll be discussing about the pump therapy will become obsolete, maybe after 2 years. With this, thank you, Abdullah, and thank you, Dr. Vishwajit. And can you just conclude the session and thanking all the speakers so we can take the panel discussion next? We are already late. Over to Dr.
We should move to the panelists because we are running late.
Already. Okay, good.
Thank you.
So, inviting Dr. Amit Gupta, who will be the moderator for our next session. He will be also introducing all 3 eminent speakers. Ronald is joining from UK, so he's not like in the middle of the night. So he's not from Hong Kong. At present, he's not in Hong Kong. He's in UK. We have with us Dr. Fatia. So Amit, please introduce, and our Jackie, Vice President of International Diabetes Federation. So with this, I request Amit to introduce them. Amit is a senior diabetologist based at Noida, New Delhi. He is currently chair of International Diabetic Federation, a school of diabetes. That's a very important organization of IDF, and he is going to chair for that. So with this, I request Amit to introduce the panelists and to introduce the topic. Thank you.
Thank you, Bansi sir. And a part of the introduction is already done by Dr. Bansi sir. He has introduced everyone, but still, I would like to mention that we just heard 3 excellent talks on 3 different topics, and I would like to welcome the faculty, Dr. Jackie, Dr. Ronald Ma, and Dr. Fatia. Audio-visual team, can we have the slides, introductory slides of all the 3 panelists? So let me just formally introduce Dr. Jackie Kasof Malov is from Lebanon, and she is the founder and the president of the DIALAB. And also she is the vice president of the IDF, and she for the non-healthcare position, and she holds a PhD in public relations. And we have all seen her advocacy efforts at almost all the levels. And recently she has been appointed as one of the very important key positions for the NCD Alliance also. So welcome, Dr. Jackie. And now I would like to welcome Dr. Ronald Ma. Dr. Ronald Ma is a very dear friend, and he is a great researcher in the field, doing amazing work in the field of technology, obesity, diabetes. And Dr. Ronald Ma is currently based in UK, and he is a prominent endo and diabetologist in Hong Kong. And he is a professor at the Department of Medicine and Therapeutics at the Chinese University of Hong Kong. So welcome, Professor Ma, and we look forward to have a conversation with you. And now it's my turn to welcome Dr. Fatia from UAE. Can I have her slides? Fatia is again a very prominent field in the field of diabetes and endocrinology. And she is a consultant endocrinologist and head of the endocrine department, Dubai Hospital. And she is director of the medical division, Dubai Hospital, and member of the National Diabetes Committee, associate professor in the Dubai Medical College. And she is also the MRCP PACE examiner. So I would like to welcome all the 3 panelists. You can unmute yourself. And this is going to be panel discussion. And to kickstart the panel discussion, we know our theme for today is we are talking about the leveraging technology for diabetes, equity, access, and accuracy. Maybe we can also add advocacy also. And so my first question would be it is going to be with Dr. Jackie Malov. And I would like to ask her, when we talk about leveraging technology for diabetes, equity, access, accuracy, how would you like to set the stage for this conversation when we all of us are here, and why this topic is so urgent and relevant today?
Yes, thank you for the question. I'm very honored to be here. Thank you for inviting me to talk about this very critical topic, as we've heard of many colleagues explaining the importance of the digital tools. So now to set a little bit the stage and the scene of why it is so important, I will kindly remind you that in the latest atlas from the International Diabetes Federation, we have seen the numbers increase to be nowadays 589 million people living with diabetes. And there is a desperate need for innovative, scalable, and accessible solutions more than ever. The need is now more than ever. We need to really take decisions yesterday, if it's possible. So especially those solutions need to be implemented, not just where people can find them affordable and accessible, but mainly in the low and middle income countries where we have the underprivileged population. It needs to be accessible to all because we are talking about equity, about access, and about leveraging on the existence of technology. We need to bring the care closer to where people are and help improve both the access and the quality. For that, we will discuss later what are our challenges and many other features. But at this point, I would say we must ensure the serve all people, as I mentioned, not just those with privileged access.
So thank you, Dr. Jackie, for setting up the stage. And I would like to ask Dr. Ronald Ma as well as Dr. Fatia. As you know, the Asia is one of the largest continent, in fact, the largest continent, and we have so much diversity. If you talk about, if you start from the Middle East and you go to the Hong Kong, India, Southeast Asia, we are so diverse. And we are the hotspot for the diabetes. We have the largest number of people living in diabetes are living in this region. So how can technology help us manage this better? So Dr. Ronald, this is my question to you.
Yeah, thank you for the question and the invitation to join. So I think there's several levels. I think first of all, I think we need to understand what we mean by diabetes technology. These things like apps, tools of course access CGM, as well as pumps for people living with type 1 diabetes or pregnant. Earlier today about sort of the benefits of CGM, and this is on an individual level. It has lots of benefits that we're all familiar with: better monitoring, alerts, using risk of hypoglycemia, but also perhaps can help visualize glucose control.
Sorry for interrupting you, Professor Ma. Yeah, your voice is not very clear to us.
No, sorry, maybe my internet connection is not very good. I think on an administrative level, population level, technology has the opportunity to help manage a large number of people because there's opportunity to do sort of cohort level of population analysis to identify those who are suboptimally controlled and try to identify risk individuals. So I think technology has a big role to play in terms of this large number of people with diabetes in the future. Define risk and also improving control.
Professor Ma, I'm really sorry, but I was not able to listen to a large part of your conversation. Maybe you can try to reset your connection, or maybe you can also try to switch off your camera so that bandwidth improves. So this is one of the options.
I will probably switch off my camera then.
Yes.
I think
yes.
The main point I would want to make is just that I think technology has a big role to play given the large burden of diabetes in Asia. And I think this applies to both apps on the individual level as well as sort of in terms of healthcare administration using the data to stratify and identify those at risk to try to see how we can target care better.
Thank you, Professor Ma, for your comments. Dr. Fatia, first of all, welcome, and I would like to ask you that we know that we are the hub for the largest number of people living with diabetes, and we vary in the region as well. So if we need to talk about from the policy point of view, what are the technologies you think that these are the technologies are the must, which must be which can help us manage this diabetes epidemic in a better way in the Asia?
First of all, many thanks for the kind introduction, Professor Gupta, and also thanks to the organizer for inviting me to take part in this interesting panel. I can just comment on, how can technology help to manage diabetes better in our Asian subcontinent. Probably they are, I can look at them as a four main pillars that can support in this perspective. One of them is, as already our previous speaker has spoke about, the use of CGMS or use of a smart, technology which is connected to the insulin as well, pen, which will allow us for a real time blood glucose, tracking, and it also will help our healthcare provider to access patient data remotely and also adjust the treatment plan accordingly. The other issue that the telemedicine, which we all learned about since the era of COVID, which I think we need also to invest in, because that's not only will allow us, to reach, areas where there's limited resources, like in terms of a specialist, but also it will save time for our people with diabetes to travel long distances. Also, having the era of the AI as well as the data analytic will also allow us as a healthcare provider to identify those individuals who have a high risk, or those, with a complication to be detected early, and of course to prioritize their treatment and also improve their outcome. On the other aspect also, we've got the digital education, the current one which we are doing for our healthcare provider, because if we train our healthcare provider and we provide them with all the educations, then definitely that will reflect on our patient, and ultimately, then we can educate our patient in all the perspective of the lifestyle. And I go back, and why I just went back, and I know that your question was not related to this, to the policy, but just because you had put this question to, our previous panelists, so I thought I just wanted to highlight this so that the audience does not miss this. And in terms of the policy makers, I think it's very important that, our colleague in the region, whether our policymakers from, Health Institute or Ministry of Health, or even our NOGs, and also our healthcare providers, as well as the industry, that we need to put hands in hands in order to provide these tools to our patient. We already know that, these tools are very expensive tools, but there is always a way that we make them available for our, patients or our people with diabetes in our region. I think it's very important. We as, healthcare providers, most of us also will serve, societies. We network with international societies. And I believe that we are all can, put hands in hands and, provide that advocacy, through different channel. And then, we can convince our policymaker in order to support us for the better life of our people with diabetes. Over to you, Dr. Gupta.
Thank you, Dr. Fatia. And you are very right in saying that the technology is available. We need a lot of collaboration, and definitely the AI and the data analytics is going to open up an entirely new space where we are going to have new insights, probably how to intervene better in a community space. And just to say, tell you a story about the technology adoption. Sometimes I was just in a flight a couple of days before, and there was a medical emergency in the flight. I mentioned that on my Twitter account also. And I was surprised to see that there was no glucometer on the flight, and there was not even a pulse oximeter on the flight. And I was more surprised to know that this is view all across the globe. So there are many other international airlines also where the same kind of, even the basic tools are not available, and we are talking very advanced technology. So the policy is something which needs to be highlighted, and no chance for the advocacy should be missed. You are very right in saying that. So Dr. Jackie, I just highlighted this incidence, and we are talking about what should be an ideal tech world like. And you represent IDF, you represent Lebanon Diabetes Organization, and you also represent many other organizations as a leader. So what is your thought on this? And just, you also please feel free to come in anytime and take part in the discussion.
Yes, thank you for this question. It's actually super important, where it gives me the floor to express about the vision of a tech-enabled future that we have at the International Diabetes Federation. We see a tech-enabled world means that no one is left without technology. It's a world where people with diabetes, no matter where they live, have access to trained healthcare professional. And I emphasize on the word trained, because digital literacy is really important. They need to have timely information and supportive care works, all of which are enhanced by digital tools, of course. So if I were to mention the best example in this case that has been evolving with the technology evolution, the School of Diabetes, and you yourself now will be involved in revamping, adding courses, short ones, long ones, different multi-stakeholders are going to be participating, even capacity building, health literacy. This is the best example of how IDF envisioned the future of technology within the organization. And I wear several hats, as you mentioned. So if I were to speak as the founder and president of Dialab in Lebanon, I would say that I'm very happy to see how we are leveraging on technology by using the e-newsletter that goes to the email of every person on their smartphones. Our social media with its activity brings the right information to the hand of every person living with diabetes, or with the purpose of prevention in some cases. And if I were to say in one sentence, I would say it's about giving people tools to live better, not just to treat the symptoms. So the ideal scenario I would say that ideal scenario would enable early and accurate diagnosis, would support continuous glucose monitoring, the CGM, would provide personalized education and reminders, which in some cases can be life-saving, would offer remote consultation, would use artificial intelligence for the good, because it's not always used for that purpose, and it would help for clinical decision-making, and would be available in multiple languages. And this is also a key it has utmost importance to speak to the people in their language, in their cultural settings. There are some that can sometimes be a major barrier. So we have many components for the success. Would you like me to jump to those, or just wait for?
So let me just congratulate you that your newsletter is one of the best newsletter which I receive in my email. And Dr. Bansi is also many times commenting on that. Look, this newsletter should be like this only. And your social media handles are really, so that is again the use of technology, because it is not about showcasing what you are doing, but it is also about reaching out to people and telling them, motivating that how it is to be done. And my question, as you have given me so many food for the thoughts for the idea of School of Diabetes. Thank you for that. And let me come back to Dr. Ronald Ma. And Dr. Ronald Ma, my question again to you is regarding the training and awareness. We know that a lot of technologies are still there for almost a decade, like CGM, like AIDs. They are evolving and they will keep evolving. But still, the uptake among the healthcare professionals is very low. We see this as a challenge that even the CGM is available, but the healthcare professionals, they are not using that. They are not talking about the AIDs. So where are we lacking in this education and awareness, and how we can improve that?
Thank you for that important question. I think we are all trying to sort of help educate and also bring the role of technology to our colleagues, no matter in primary care or even specialist levels. For example, colleagues who are comfortable using insulin pumps are limited, and also the number of people using CGM. So we try to introduce it in different ways. One is to get our diabetes educators to help patients start on CGM and educate them how to use it. We also organize some workshops through different channels to try to bring CGM and pumps and other technology to colleagues in educational events like this. and also just trying to make sure that there are sufficient access to people who want to use technology. So, for example, educational videos on demonstrating how to use it. So I think there are lots of things that we need to do to try to make technology more accessible, especially if we're trying to advocate for broader access and equity for access. So I think we need to explore all channels that are available and use every opportunity to try to.
Thank you, Dr. Ronald Ma. Thank you, Professor Ma. And I could hear some of your points, and you have mentioned that, yes, we need to have a novel approach to educate healthcare professionals, and we also need to have a novel approach to reach out to the people with diabetes as well. So, Dr. Fatia, I would like to ask you one very important question. And this question comes from the background that whenever we talk about technology, there is always a risk that a certain group will benefit more and a certain group will be left behind. And this is, so I'm talking about the digital divide. So how do we address that so that nobody is left behind with the use of technology?
I think we've got a major issue here because I think in spite of all the advances that we are seeing, and there's rapid revolution, and every day we end up with a new device and a new CGMS or pump and all, I think on the contrary, we are not providing the enough education to our healthcare providers so that they become more confident to deliver this knowledge to their patient. So if the healthcare provider lack this, definitely, the way that they transform the information to their patient would not be optimal. And I think many of our patients also, because of their lack of the education, they think it is a toy rather than it's a tool to help them and to support them. So, and then also we have the time. I think all of us, and I'm sure, it's not only in UAE, but across the globe, that now the physician are asked to, to show productivity in terms of the RVU, revenue cycle. So we are pushed to see more and more patients. So the time that also we spend with our patient is not enough. And also we know that we have lack of diabetic educator across the globe, especially in our region. So that's the support, which is also lacking in that terms. So even if we provide, like I come from a high income country where, for any nationals, we provide them a CGMS free of charge without any, fee. And for a non-national, if they are insured, then they can, get the device, but other, they will do from, cash payer. And in spite of this, even those, nationals who we provide them with all those fantastic tools, which is available at their hand from any institute across United Arab Emirates, unfortunately, our patient does not, either, they don't scan, then they will find lots of time that you end up with gaps in the scan and all. It's not the matter about some people will get it or some people will not get it. Even those who get it, we are not doing the best for them. So I think we are still lacking behind in terms of, education. So I would stress mainly on that we need to educate them. And the education, unfortunately, sometimes we think, even unfortunately, even with the industry partner who are the technology maker, they think that, once they introduce these fantastic tools to us, then it is just one-time session of presentation and that's it. Because, we all know the terminology. If you don't use it, you lose it. So it's very important that we should, be trained on a constant basis, to have that. And now in terms of discrimination, that some people get it and some people does not get it, I think all is about diabetes discrimination. This is what we are saying. Because what happened, I think I take this platform, most of the industry are not helping us with this. I think day by day, the medication are becoming very expensive. The strips, okay, maybe we managed to get the strips are easy because now the glucometers are a bit falling out of favor in some part of the world. And on the other hand, we are having CGMS, which is also very expensive. Even in my country, we think it's, having for 14 days, a sensor for 14 days, it's very expensive. So if we want to ask our authorities to have equity of service and equity of distribution, then we need to be also realistic as a healthcare provider, as industry, and we should not put the blame on the policymaker because, okay, maybe I have some leadership roles, but at the end of the day, I work also as a healthcare provider and I see patients on a daily basis, but this is our, they are collective of things, which is we need all of us to work really, to improve this. And, with some organization like the IDF, I think we need to put a pressure on this. I think in breast cancer, people had succeeded, to advocate for breast cancer. And I think we still, as, diabetologists, we are still, till date, we are struggling in spite of having all those, expensive technology and expensive medication. We just heard from Dr. Baksh, how the cost of a vial, of a medication for someone with type 1 as well. Over to you, doctor.
So I
yes,
just want to add here that, listening from Fatih, that in Dubai also, or in UAE, if you have a lack of educators and struggling for the cause, I mean, then what happened to the countries where it's really a challenge? And Asia is a country, I mean, it's a continent. It is such a disparity. One side, we have the people who are from developed world. We have people from Hong Kong, Singapore, from China, from Japan, from UAE and Saudi Arabia. And we have people from Pakistan, Bangladesh, and some of the countries where even some of these technology are not available. But still, basic thing which we all can get is the educator. And educator will definitely, whatever the technology which is available in that particular country, if we educate them properly, like as Fatih said, that even if it is available, some of the people will not scan there and continuous glucose monitoring. Even you put them on that, and still is. As far as cost is concerned, you were talking, but still the users of GLP-1 is highest in Middle East, and the cost is very high with the GLP-1 usage. Still, in compared to the use of CGM and pump in Middle East is less. There was a debate in last ETTD. If you have given a choice between a continuous glucose monitoring and using a Mounjaro, which would you like to use? I mean, definitely its monitoring is more important than therapy. Unless you monitor, you will not act on it. So, I mean, if you don't have something to monitor, you will not act on it. So what is your saying that as it endocrinologist, as an endocrinologist, would you like to put more patients on a GLP-1 therapy, which is right the therapy, or would you like to monitor more patients on their glucose control?
Dr. Fatia, yes. You can answer.
Unfortunately, Professor, Banchi, this, people now look after their image. Even, they're using GLP is not because they want to get their sugar control as much as they want, to get the image. Because, the message we are passing is wrong. That's the problem. Our message we are passing is wrong.
Dr.
Now,
Fatia,
please.
Yes, please go ahead. Yes, please go ahead.
Yeah, I just wanted to say that, I wanted to audit this in our department where I work in our institute to look, if we are doing good to our patient in terms of dispensing CGMS, to look into their A1C. I found not only missing data, I also could not trace, the date that, the tools was, dispensed to them to see, when the A1C had improved prior or post, treatment. Sometimes people, they just simply get fed up using it because, as Iram had mentioned, there's so many sophisticated technology had developed over the years within these. They became more complicated. And what we want to look at, something which is simple, easy. Sometimes even our healthcare provider finding it difficult. They will keep saying, it's not enough we have one session, 1 or 2 or 3 sessions that we need to do this. We need also to integrate those tools because, I think we should also leave the era of having, patients showing us on their device. We need to integrate it in our electronic medical record. I mean, I'm not sure about rest part of the world, but at least where I come from, we've got an electronic medical record where we try to integrate most of the devices with. But then again, this is a process which is also time consuming. It's also an issue of the software, which is, sometimes because of the, the license, sometimes the authority will not also allow these, devices to be in-house. We try also to regulate that to save, to protect the data of our patient.
So, Dr. Fatia, I totally agree with you. And at the same time, I would like to say that this whole concept of GLP-1 is also somehow misplaced because most of the time, the indication is obesity, not the glycemic control. And this is also the perception of the patient most of the time. And they're, as you have rightly pointed, this is the matter of image. So this brings to me the last set of questions because I would be mindful of time. So we may not be able to cover all the questions. Dr. Jackie, Dr. Fatia's answer has set up the stage for the real world challenges. And you know that these are all the real world challenges which we face: no scanning, no availability, discrimination. So what is your take on this and how do you address this?
Okay, I would like just to remind the audience that other than the different hats I wear, I'm the mother of a young lady living with type 1 diabetes. So I bring in as well the lived experience. And I insist on mentioning that because they have to be always a part of any decision because it's related to their lives. They are at the center and they should always be at the center. If I were to mention the components quickly, it will definitely lead us to what are the challenges. So the component for a successful leveraging on technology would be equitable access. And I think we heard a little bit about that. I wouldn't say discrimination because discrimination would usually happen on purpose. I would say equity. We lack equity in that regard. We need a strong digital and health literacy, and Fathia mentioned some of that, and it's a must go for need. And we need training for healthcare professionals. Also, it was mentioned, this is a key component. We need localized and culturally appropriate educational content. We cannot import from the West and implement it in our, for example, MENA region or in Asia, in the rest of Asia. We need to tailor it for our people. And of course, we need supportive health policies. So that leads us to the challenges in the real world, which is the limited internet connectivity. It's not about just giving a smartphone to somebody or a digital tool. We need to know if they have for example, a good internet connectivity. And this is a challenge not only in the rural areas, but in most of the low-income countries. We need also, a main challenge is the low health and digital literacy. Another main challenge is the language, and the most challenging barrier is definitely the high cost. In Lebanon, for example, nothing of that is covered. There are centers and NGOs who try to help and support. Unfortunately, diabetes is still not set as a priority for the policy makers. So if I were to finalize, because I know we don't have much time, with a call to action, I would tell the policymakers, please invest in digital infrastructure, subsidize essential tools for people, and to the healthcare professionals as well, I have a call to action, embrace technology, promote tech-based care models while guiding the people with diabetes through them. And then to the people living with diabetes themselves and other NCDs maybe, there is also a call to action to engage with digital resources. Sometimes they live in denial. They don't want to take the extra burden other than all the decisions they make. And I would tell them to advocate for their rights and participate in shaping more inclusive healthcare systems. So, and to close, finally, I would say, to all of you and all of us, technology, when guided with compassion and purpose, becomes a bridge, not just for better care, but for better lives. So let us keep building those bridges together. Thank you.
Thank you, Professor Jackie. And I would just like to take final comments from Professor Ma and then Professor Fatia. Professor Fatia, you can give your final comments for this panel discussion.
Well, I think we need to invest in education. And I think that is the key for most of our, if we want to, go forward. And plus also, as, Jackie had, rightly mentioned, the policymakers, the insurance, the, reimbursement, because, we deal lots with the insurance. And again, that part also we need to look at. Plus also our industry partner, and the triple P, which is the public-private, engagement as well, to bring a comprehensive, teamwork in order to drive the technology to another step. Because if we don't do it now in the Asian country, the other world will be also excelling, and they will exceed us into this. And I'm sure in this part of Asia, they are the mind, they are the brain who are after the technology, whether, in India, in China, in Pakistan, in Lebanon, in most of the country, GCC. And I'm sure we have lots of people who come with lots of a good innovation, which is affordable to our, our population. Thank you very much for giving me the opportunity.
Thank you, Dr. Fatia. And I would like to thank all the panelists for having a wonderful discussion. And we know that technology is the future. And Asia has the technology. We need probably more education, and organizations like DSG and IDF can do a lot in terms of education. And I will hand it back in time to Dr. Bansi Sabu, Dr. Abdul Basit, and Dr. Bashir for the final conclusion and the remarks.
So thank you, Amit. First of all, the biggest example of the digital connectivity is that we all are connected and sitting in our home, and, all of us are listening each other, and more than 1,130 doctors who were there and they were listening to you. So, that's the biggest advantage of this digital connectivity. As far as Asia is concerned, I think most of the Asian countries have good digital connectivity. And I can see that Ronald, who is just now in UK and having a poor internet connection. So I think we should not feel that we have a better connectivity than even someone who is in UK. And thank you, Amit, for wonderfully moderating it. Thank you, Dr. Jackie, Dr. Fatia, and Dr. Ronald for as a panelist. You could join. Thank you from DSG, from myself, Dr. Abdul Bashir, and Bishwajit as the Secretary and President, and Nadima, our board member. We all are thanking you, all the panelists and all the speakers. My friend Ashraf, also you please open your video. We can have one last photograph, and then I will request Bishwajit to give final vote of thanks. And again, I will say Nadima, because we are missing you since last 2 days because of, again, maybe a connectivity issue was there with Nadima. So her final words before vote of thanks by Bishwajit, and then we can close the session also. Once again, thank you to DSG board and those who are member of Diabetes Asia Study Group, requesting them to join tomorrow for our annual general body meeting. The recent addition of membership is Fatia, and from congratulations, and we are thankful to you that now Emirate Diabetic Society and Logan Society is official member of DSG, and you are also the member. So please join for our AGM. Over to Nadima and to Vishwajit for final words of thanks.
Thank you, Banshi. Thank you all. Thank you for such a rich and engaging session. I'm very grateful for our speakers, panelists, and chairs. Today it was very important session about technology and focusing in equity and access, which must remain central. Thank you for the participation, and thank you for the organizer, and special thank to Roche. Thank you all.
Vishwajit?
On my side, thanks to everyone. And I think in future we will again meet in this kinds of, the programs. So at these moments, from my side, so we have successfully, ended a good program.
Asher and Ashraf, please open your video so we can have one photo. If you can. Yes, good. Thank you.
Thank you, everyone.
Bye. Good night.
Good night. Thank you.
Bye-bye. Thank
Recording
you.
stopped. Everyone.
Bye-bye.
Bye.
Bye.
Bye.